Thank you very much, all, both the speakers and the chairpersons. We move to our next session. Thank you, moderators. Our next session, the moderators are Dr. Ravi Shraval, Dr. Jenish Shroff, Dr. Suyash Tated. Chairpersons are Dr. Pintu Nata, Dr. Neeraj Yadav, and Dr. Bhavesh Roy. I would request chairpersons to introduce both our speakers and then also discuss, present the case, and then ask the speakers to go ahead with their presentation. Over to chairperson.
Good afternoon, everyone. It is an amazing conference going on, and we have an excellent debate coming up by Dr. Samir Rane and Dr. Jignesh. So let me cut short the time and start with an introduction. Dr. Samir Rane is MBBS and consultant cardiologist who has done EP fellowship and worked as assistant professor at UN Mehta Institute of Cardiology in Ahmedabad. And Dr. Jignesh Patel is also MD Medicine from VS and DM Cardiology. He has done from Bombay Hospital and Medical Research Center. He is currently associated with Sal Hospital, Shelby Hospital, and his special interest is in pacing and device implantation, ICD, as well as cardiac resynchronization therapy. So let me first introduce the case that we are going to debate. So this case is a 60-year-old male with class 2 shortness of breath showing LAHB with right bundle branch block and QRS duration of 120 milliseconds with PR interval of 240 milliseconds. His 14 days loop recorder has shown PVC burden of 4.5%. And there is history of cardiac syncope twice over last 2 years. She has history of old anteroseptal MI with recanalized coronaries in a recent coronary angiography. This is proven by cardiac MRI, also showing small apical scar with ejection fraction of 42%. Apart from the medical optimization, what this patient should be offered. So Dr. Samir Rane will talk in favor of ICD implantation as a more suitable initial and preferred device therapy. And Dr. Jignesh Patel would talk in favor of dual chamber pacemaker as a treating modality for this patient. Over to you, Dr. Samir Rane.
So at the onset, thank you, Kamal sir, for giving me this opportunity, to talk on this platform. And congratulations to Team Cardiocon for organizing these fantastic learning sessions. A warm good afternoon to Dr. Jignesh Patel, my colleagues, and also to today's chairpersons and moderators. I'll be representing the blue corner in today's discussion. So this is the case which Neeraj sir has already pointed out. And the ECG of this patient shows a conduction system disorder, probably due to a scar formation, may be degenerative, but we may consider that it may be because of a scar, which may also be progressive. Prior ECGs would have been helpful to compare. Then based on the information from loop recorders, there is no evidence of paroxysmal AV block or sinus node dysfunction. It shows an insignificant number of PVCs. Desirable information about the PVCs would have been the site of origin, monomorphic or polymorphic. Also, if these PVCs were R-on-T PVCs, which if present, maybe would have been related to the history of cardiac syncope in this patient. Then episodes of cardiac syncope can be both due to tachyarrhythmias and bradyarrhythmias. The loop recorder suggests that maybe bradycardia is probably not the mechanism for syncope in this patient. Then most of the diagnosis of an old anteroseptal MI is made on the ECG findings of a QS pattern in the precordial leads of V1 and V2. Mac Alpine suggested that despite much information in the literature indicating that this is an unlikely pattern for pure septal infarction, such ECG diagnosis is frequently given. There was evidence of LV dysfunction, and this patient underwent a cath, which showed recanalized coronaries. Then his cardiac MRI showed a small apical scar with LVEF of 42%. Well, based on the information provided by the cardiac examination, I feel that there is a disproportionate LV dysfunction when compared to the scar size. More information would be desirable on the characteristics of the scar, such as the pattern of late gadolinium uptake, like whether it's subepicardial, subendocardial, or intramyocardial in location. Ischemic scars tend to be subendocardial to begin with, whereas myocarditis can be subepicardial, intramyocardial, and can also have mixed patterns. T1A weighted images are gaining importance for tissue characterization, also regional wall motion abnormality. The extent and architecture of fibrosis of a scar, even in the absence of contractile dysfunction, leads to electrophysiologic dearrangements that increase propensity for ventricular arrhythmias and sudden cardiac death due to scar-related re-entry causing ventricular tachycardias. Then role of cardiac MRI is basically risk stratification in sudden cardiac death remains impeded by one-size-fits-all approach with over-reliance on traditional factors like reduced LVEF alone. Then this approach fails to identify majority of individuals, around 80%, who suffer from sudden cardiac death events. And personalization of treatment and identification of the pathophysiological mechanisms for sudden cardiac death can help to identify these subset of individuals. Cardiac MRI is beneficial to address these limitations, but widespread implementation, then the lack of consensus regarding quantitative, infarct, and tissue heterogeneity standards, as well as definite outcome studies are lacking. A prospective randomized control trials based purely on cardiac MRI guided decision making for primary prevention ICDs and including LVEF values of across a wide range will help address all these issues. Then the role of electrophysiological study in this patient is important, where the cause of syncope is unexplained or non-invasive evaluation has not given us much information about the mechanism. There are class 1 and class 2A recommendations basically to assess the inducibility of VT, evaluate the episode of syncope with ventricular arrhythmias as the suspected cause. You can guide catheter ablation if required, and to assess the risk of progression to a complete AV block. Then in patients with syncope and the presence of bundle branch block and reduced LVEF, VT ventricular tachycardia may be induced during electrophysiological studies in up to 42% of cases. Using standard evaluation, electrophysiological studies, and implantable loop recorders, Moya et al. Had shown that among 303 patients with bundle branch block and syncope, the episode of syncope can be due to VT and bradyarrhythmias. So we have not ruled out the presence of infiltrative disorders like for example, sarcoidosis, whose cardiac MRI patterns can mimic those of myocardial ischemia. Further investigations can be done like FDG PET scan or CT scan of thorax. And further characterization of the apical scar can suggest its role as a potential substrate for re-entry VT episodes and also the nature of the disease. Both EPS and cardiac imaging can help select the appropriate therapy and catheter ablation. AICD or both can then be offered. Then a detailed discussion with the patient and his relatives is required prior to therapy. And recently, Dr. Neeraj had also posted this quote on the IHRS group in reference to one of his patients, and also to stress upon the importance of CPR training in the family. The only difference between syncope and sudden death is that in one, you wake up. So thank you.
Good afternoon, everyone. So we already know the case history that has been already covered by our friend Dr. Samirane. So he'll be choosing an AICD in this particular patient considering the old MI. And according to me, the pacemaker is sufficient to treat this patient rather than over treating this patient with the AICD. Why? If you look at the case analysis, here we have a case having a patient 60-year male having a bifascicular block with the first degree AV block that is symptomatic because patient had a history of the syncope twice over last 2 years. And other characteristics which has been given are the very small apical scar on the cardiac MR and ejection fraction of just 42% and non-significant findings in the loop recorder that has been put for the 14 days. So we'll not go in the details of the cardiac causes of the syncope, that was already covered. In our case, the detailed history of the syncope is not given. For example, whether it's associated with the palpitation, whether syncope occurred during the exertion, was there any relation with the position, any and other ECG characteristics like R1T phenomena and all that. So that will further help in guiding the treatment proper. So here the further evaluation is definitely necessary, either in form of the EP study as well as the ILR, as the EP study is not specific, because definitely a positive finding on the EP study will help in guiding the treatment. If there is a prolongation of the HV interval, then it will definitely, or there is a demonstration of the second or third degree AV block, definitely it will help to choose towards the pacemaker. And if there is an induction of the ventricular tachycardia, then will we go towards the ASD placement. But the negative EP study does not rule out the possibility of the AV block or tachyarrhythmia as a reason for the syncope. So second thing is a implantable loop recorder. Definitely it is costlier, but it will give a better insight in the cause of the syncope. But it is even costlier than putting a pacemaker sometime. So in our Indian population, it is very difficult to put a ILR in each and every patient. Now, if we come to the data, if the patient having a bifascicular block in the baseline ECG and having a syncope, if we look at the etiology in such patients, around 40% reason in such patient is just neurally mediated. In around 45% of the patients, the cardiac etiology is found. So they studied the 55 patients prospectively. Out of the 55, 25 patients had a cardiac syncope, and out of this 25, AV block was present, and it was the reason for the syncope in almost 20 out of 25 patients, and VT was present in 1 out of 25 patients. So that is the obvious reason. Whenever we have a baseline ECG showing a bifascicular block with a prolonged PR interval, the reason for the syncope in such patient is most likely a AV block, and that is a conduction disturbances rather than a tachyarrhythmias. So another prospective study and another prospective various data has shown that most of the bifascicular block will have a progression to the higher degree AV block over the period of time. So that will be also defined by the HV interval in the EP study. If the HV interval is more than 70 milliseconds, there are 12% chances, 12% more chance to the progression to the AV block. Similarly, if the HV interval is more than 100 milliseconds, the risk of the progression to the AV block doubles. So we can say that in our patient, at least in this particular patient, having a baseline ECG showing a RBBB plus LAHB with the prolonged PR interval, most likely reason for the syncope in our patient is a AV block. And as the tachyarrhythmia or the ventricular tachycardia is very less likely, or the remote possibility we can say, because here we can see that the ejection fraction of just 42%, that is a mild LV dysfunction with a very small apical scar, as well as there is no any significant arrhythmias noted on the loop recorder. The chances of having a tachyarrhythmias and giving a syncope in this patient is very, very less. So we'll come to the various data which will support that why we should choose a pacemaker in this particular patient. If we look at this prospective study, they randomized around 27 patients having a bifascicular block with the unexplained syncope, and they were offered a UVI pacemaker with the bradycardia detection ability. And they were followed up for up to 60 months. And what they found, out of these 27 patients, 14 patients, that is almost half of the patient, had a progression to the higher degree AV block. That means that most of the patient having a baseline bifascicular block with the syncope, over the period of the time, they needed a pacemaker over a period of time in the lifetime. So there is another study which compared the permanent pacemaker implantation versus the EP study in patient having a bifascicular block and the syncope. And what they found that this is a prospective cohort study, and they randomized the 77 patients. Out of these 77 patients, 36 patients were given an empirical pacemaker therapy, and rest of the patients were offered a decision based on the EP study, whether to put a pacemaker or whether to put a AICD or not to just treat and wait and watch. And what they found in the result, in the pacemaker group, there were less chances of the syncope, and when the decision was taken after the EP study, there were more incidents of the syncope at the end of the follow-up period. So we can say that whenever we are putting a pacemaker in patient having a bifascicular block and the syncope, we are definitely giving them a syncope-free survival over the period of time. And similarly, if we compare this study, that is a prospective study, around 56% underwent the pacemaker and 59% underwent the ILR implantation. And what they found at the end of the follow-up, in the pacemaker group, the syncope-free survival was more as compared to the ILR group. And on top of that, of those who were offered ILR, around 60% of the patient had to cross over to pacemaker because of syncope and because of the progression to the AV block and because of the finding of the high degree conduction disturbances during the ILR monitoring. So if we come to the guidelines for the indication of the pacing in patient with the bundle branch block and the syncope, here we can see that whenever there is a bundle branch block with the syncope with the abnormal EP study, definitely when the HV interval is more than 70 milliseconds or there is a demonstration of the second or the third degree AV block, then it's a class 1 indication. As well as whenever there is an alternating bundle branch block, it's a class 1 indication. Our case falls into this. It becomes a class 2B indication because whenever there is a bundle branch block, there is an unexplained syncope and the non-diagnostic investigation. We have not given a data of EP study or ILR, but here we can say even if we consider that EP study is not non-diagnostic in our particular case, our case will be a class 2B recommendation for putting a permanent pacemaker here. And another important thing is if we look at the indication and the guidelines for putting an ILR, it's a class 2A recommendation in such patients because the ILR is a costlier thing. It will be better to put a pacemaker rather than going for ILR in such patients if the patient is not affording, because anyway the putting a permanent pacemaker, it will also give a bradycardia event monitoring over the period of time. And second thing, the EP study itself is a class 2B recommendation because the findings of the EP study in this particular patient will not be that it will not be that informative because the negative study will not rule out the cause of the syncope, whether it's a AV block or not. And we'll leave this part to the EP specialist after my topic discussion. Now coming to the why not to put a AICD, if you look at the guidelines, it clearly says that because in patient with the bundle branch block and the unexplained syncope, the AS will be recommended when the ejection fraction is severe, LV dysfunction is severe, ejection fraction less than 35%. Then only it is recommended because the ventricular tachyarrhythmia causing a syncope, the incidence is only when it is a significant LV dysfunction. In patient with a mild LV dysfunction with the small apical scar, such patients are very less likely to get a tachyarrhythmias in their lifetime. So the AICD is not warranted in such patients. So here in our case, ejection fraction is less than 35. So we have to take a decision after doing EP study or ILR whether to put a pacemaker or not. So coming to the another thing, that is a guidelines for the AICD implantation. As I already discussed, it clearly says that primary prevention in patient with the ischemic heart disease, AICD implantation is a class 1 recommendation. But when it is less than 30, ejection fraction is less than 35%, not when the patient is having a mild LV dysfunction and the small apical scar. So in our patient having a bifascicular block with the prolonged PR with symptoms, it becomes an indication for the permanent pacemaker implantation. With a mild LV dysfunction, small apical scar with EPS burden of 4.5%, there is no need of ICD and no need to overtreat such patients. It is putting a ICD in this patient will be something like telling a fan in the cricket stadium to wear a helmet just to prevent a head injury while watching a test cricket. So I'll not put a AICD in this particular patient, but the permanent pacemaker will be sufficient enough. And even you can give an argument that the AICD will protect from both. It will protect from the syncope as well as it can even give a shock during the ventricular tachyarrhythmias in the future. But is it really needed? But I think it's not required. And there is no need to overtreat such patients. So we can go ahead with just putting a permanent pacemaker. So to conclude, the evaluation of the patient thoroughly before choosing a device is really very necessary. In our patient, permanent pacemaker implantation is more sensible and it is sufficient enough because the conduction disturbances, AV block is the most likely reason in our patient, considering the fact that patient is having a bifascicular block with the first degree AV block And second thing, the EP study findings are non-specific. Even a negative EP will not rule out the AV block as a cause of the syncope. And similarly, putting an ILR will be a costlier affair. Even it is expensive than the pacemaker itself when it is kept for the longer period of time. So even a significant number of the ILR patient will need a PPM, approximately 60% of the patient. So the VT is not an obvious reason here. Considering the mild LV dysfunction and the small apical scar, there is no need to overtreat this patient, and we can go away with putting just a dual chamber pacemaker. Thank you.
Thank you. Thank you, Samir and Jignesh. Both of you have put your points really well forward. I think I would like Dr. Ravish and Dr. Janish to come and give their comments.
Good afternoon, everybody. Very good discussion on the versus AICD versus DDDR. I would like to put out my points in a very simple way. First, evidence. Evidence is that AV block is the most common cause of syncope in such patients. Second, guidelines. Again, the guidelines will suggest only a DDDR in such a patient with low scar volume and all those things. So, and only syncope, no documented VT, and with the EP study becoming inconclusive. Third, but what is important is the clinical details of the patient. The devil lies in the details. What details? It's a young patient having a so-called trifascicular block. It is nearly very, you have CHB in young patients. That is completely different. Congenital CHB. Patient having a trifascicular block in a young patient is not very commonly heard of. It will be an elderly post-IHD patient having multiple attacks, having lot amount of scar in the myocardium. So unlikely this scar which is there on the apex is related to the disease which is there in the conduction system. Not directly in that. That's not like from the ischemic, only ischemic damage, what they sold, only 42% here. You will not get a trifascicular block like situation. So what I'm trying to tell that a scarring and the degenerative disease might not be only the ischemic heart disease. We are not knowing what infiltrative thing is going on inside. We don't know, have not done other studies definitely, which is affecting the degenerative system as the conduction system as well as causing an apical sparring. It may be a sarcoid also. We don't know. I am not confirmed saying that, but it may be two separate places for the same infiltrative disease. And we may only by putting this ICD, DDDR pacemaker, because we don't know in such a patient, clinical history is such difficult in this patient. Young patient with trifascicular block and an apical scar. You don't have seen any other evidence of IHD, recanalized artery. We cannot confirm it is IHD also. So maybe the scarring is also due to the infiltrative disease. Maybe the conduction tissue disease is also the infiltrative disease. And we may not get time for a third VT or whatever VP the infiltrative disease is causing. And the DDDR may not be in such a young patient. So when young, that is important. If it were to be 70, the different thing altogether. The clinical characteristic, the ECG findings, they don't match up in a young patient to only a post-ischemic heart disease patient. And so even if the EF is on the higher side, I would give a DDDR basis of the evidence on the basis of even the guidelines. But because in this specific patient, there is the problem of chance of having any other infiltrative disease which is causing damage to both. And hence, I would, in such a case, rather go with the ICD than the DDDR.
Yeah, that is the whole purpose of keeping this debate. And I think that's what the workup, I believe, was being brought out by Dr. Samirani. Yeah, Dr. Neeraj, yeah, please.
Yeah, so the same thing I wanted to convey. The Dr. Samir had put also the same similar thoughts. Actually, see, there are a lot of presumption when we are talking. Number one presumption is cardiac syncope while evaluating a syncope, any syncope patient, because cardiac syncope is one that you prove after establishing the cause of syncope. From the history, it is it is really not possible to stamp that this is the cardiac reason for syncope. And Dr. In one of the Jignesh slide, if you have seen, 40% of fascicular blocks had a neural mediated syncope, right? So history is very important to, first of all. Second point, in this patient, a bifascicular block, and whenever you hear of recanalized coronary with old anti-wall MI, just to explain the ECG abnormality and LV dysfunction that is found on echo, you have to become more alert, because recanalized LAD is one of the diagnoses that we have picked more and more etiologies of different all sort of cardiomyopathies. So bifascicular block is a conduction system disease with PR prolongation, but there is an evidence of scar, there is an LV dysfunction. And in this patient, I agree with, that sometimes it is difficult to establish the diagnosis, but I would definitely still subject him for another imaging testing like PET scan for inflammatory workup. Also, I would like to subject this patient to undergo an EP study. EP study will serve two purposes, monomorphic VT induction as well as assessment of the conduction system. I agree that majority of these cases turn out to be negative EP study in many of the times, and then probably the next step ahead is ILR or long-term monitoring, which is definitely ILR would be the best solution for that. Unless there is some evidence that there is a scar which is not likely of ischemic heart disease, there is an inflammatory process going on in PET scan, I would not go ahead with the decision of any device. So first of all, establish the etiology. Symptom and ECG correlation is must in such patients. If there is imaging evidence of something very serious like infiltrative or inflammatory cardiomyopathy, subject them to dual chamber ICD.
Dr. Janish and Dr. Suyash, your comments?
Yes, sir. First of all, thank you for inviting on this wonderful platform. Sir, the picture here is really not clear. Like patient, it could not be established that the patient really had bradycardia-induced syncope or VT-induced syncope. As Neeraj sir told, I think the dual chamber ICD would serve the desired purpose of pacing as well as ICD. So I think a patient can be subjected to dual chamber ICD, but definitely, sir, EP would give some answer. So first of all, one EP study should be done. If VT can be induced, then definitely we can put ICD with little bit more surety. I think
so,
the answer, sir.
Yeah, so let us understand that EP study in this case would be like a rapid test for COVID. So if it is positive, it is easy to make decision. But if it is negative, you still have to
Yes.
try to establish the syncope as well as some arrhythmic connection. So yeah.
Hence, the ultimate answer will be dual chamber ICD.
Yes.
Suyash?
After. Yeah.
Fully agreed with the discussion, sir. But I would like to say ICD is a weapon that we have, but when to use it needs proper evaluation in order to avoid unnecessarily shocks to the patients. And if it's totally indicated, then it's true. Here we need in this patient further evaluation, as we have discussed the morphology and other things. Then only we can go further with ICD. Otherwise, dual chamber patient. Thank you, sir.
Well, sir, your final comments.
No, the final comments have to come from you, Neeraj. You are the EP guy.
No, this is more of this is a problem that we see very often, young patients with conduction system disorder, and somehow we have tried to, now doing more and more imaging in this cases, because we are surprised by some of the results that we get. So initially, any bifascicular block, trifascicular block, syncope, which looks like arrhythmic syncope with no other. We used to put pacemakers, but we have burnt our hands. We have seen these patients coming with LV dysfunction in follow-up, and patient have come with VT episodes also. So it is always better to, investigate it thoroughly and take help of imaging in such patients. Yeah.
Thank you very much. Thank you, chairperson, moderators, and both the speakers. I think we learned a lot. That point was very validly brought out, that a trifascicular in a young guy, you're missing out on something. You must work up. Devices are not the final, and you don't have to bomb mouse hole with an atom bomb to kill all the mice. So